Yeah. Hello and welcome everyone on today's session of Purpose of Ultrasound in Pregnancy, brought to you by Apollo Cradle Hospital. To speak on this topic, I would want to welcome Dr. Jyoti Bhaskar from Indirapuram Center to give a brief background about a reputed, renowned, and well-experienced doctor here. She has done her MD. She's done her MD in Obs and Gynae, and then she's done her MRCOG, FICOG. She's a senior consultant, or I should say, a senior clinical director associated with Indirapuram Center, and she's very experienced doctor who's going to speak to us about the purpose of ultrasound in pregnancy. And we're looking forward to this session to understand why should we do it, what should we not do it, and what should we look for when we're doing an ultrasound in the pregnancy. Ma'am, we are looking forward to hear from you. All yours.
Thank you so much. And a very good afternoon to all my listeners and all the pregnant women and the couples who are really awaiting a beautiful baby into your hands. So, the topic why I have chosen this topic is because a lot of my couples they keep asking me, Madam, is ultrasound safe in pregnancy? How many ultrasounds are you really going to do in the pregnancy? What is the real purpose of the ultrasound in pregnancy? So, I thought I would just give a brief talk about that. So, first of all, I want to tell each one of you that doing an ultrasound in pregnancy is extremely safe. Till now, we have no evidence, there's no data to show that ultrasound causes a problem to the baby during the pregnancy. So, this is one myth that I want you all to remove from your mind, and even to all your family members, especially the mothers and the mother in laws who tend to keep saying, don't do too many ultrasounds, it's not going to be safe in pregnancy. The second thing I want to tell is that exactly how many number of ultrasounds that we do in a low risk pregnancy, that is when everything is going perfectly fine. So the very first ultrasound that we tend to do is when you come to us with the missed periods. It is not done immediately. The ideal time that we prefer to do it is about when you're about 7 weeks, that we would say near about 2 months of pregnancy. The main purpose of doing that ultrasound is, first of all, to see the number of pregnancies. Is it a single pregnancy? Is it a twin pregnancy? Second is to see exactly the size of the pregnancy, because that also helps us to determine which date is likely to be a date of delivery. Many women do not have regular periods. They tend to have long cycles, 35 days, 40 days cycle. In such cases, it's very difficult to determine what exactly is your expected date of delivery. Thus, an ultrasound done at about 7 weeks or 8 weeks helps us to date, helps us to determine how many weeks of pregnancy you are and what is your likely date of delivery is going to be. The third thing that it helps us to see is whether your baby is live or not, because we can hear the baby's fetal heart, we can count the heart rate, and we are able to see, yes, your baby is perfectly fine. The fourth important thing also for this ultrasound is to find where exactly is your pregnancy. Because many a times, I would say it's not very frequent, but yes, out of 100, if you look at it, one or two pregnancies, maybe ones, which are not found in the uterus, which are found either in the tubes, which we refer to as an ectopic pregnancy. Although ectopic pregnancy patients tend to present to us earlier with pain, with bleeding, but many a times we detect it for the first time when we do an ultrasound at about 7 weeks of pregnancy. Another thing that it helps to us to be able to determine that if there's any bleeding around your baby, is there any blood clots there, so that we can help you to sail through the pregnancy, because presence of any blood clots, which is known as a subchorionic hemorrhage, tends to make your baby at an increased risk of miscarriage. These are the things that we tend to get out from the first ultrasound. The first ultrasound, which is done at about 7 weeks, is preferably done as an internal ultrasound, which we call as a transvaginal ultrasound. In this, a probe is inserted into your vagina, and it is much better and more accurate way of assessing the baby in the first trimester than doing an ultrasound from your tummy. When we do an ultrasound from your tummy, because of the thickness of your abdominal wall, many a times, if your bladder is not very full, if you have a little higher thickness in your tummy, we may not be able to see the baby very well. We may not be able to exactly estimate the size of your baby. Thus, doing a transvaginal ultrasound really tends to help us to be able to determine the correct gestation, to be able to see how the baby's fetal heart is. Also, at this ultrasound, we also look for the presence of any cysts in the ovaries. We are able to see ovaries very well when we do a transvaginal ultrasound. So, are there any cysts in the ovaries, which are just collections of the water? We are also able to look at if there are any fibroids which are present in the uterus. That is, any other structural or finding that we can detect in the uterus or in the ovaries during this ultrasound. If this ultrasound comes out to be perfectly fine, it corresponds to the period of gestation that you have. If we find that the baby's heart rate is perfectly fine, then we do the next ultrasound at 11 to 13 weeks of pregnancy. But if in this ultrasound there are any doubts, that is to say that in case you are about 7 weeks and we find the baby to be small, or if you find that there's no fetal cardiac activity as yet, or we find in this particular one is that the heart rate is much less, then we may ask you to repeat an ultrasound after 10 to 14 days of pregnancy. Coming to the next ultrasound that is done at 11 to 13 weeks of pregnancy. Now, this is a very, very important ultrasound. I always tell my patients not to miss this ultrasound because at this time it is called the first trimester aneuploidy screening ultrasound, or more simply the NT-NB scan. At this ultrasound, we are able to detect what is the risk of your baby having any of the chromosomal defects, that is trisomy 18, trisomy 21, and trisomy 13. This is specifically done between a period of gestation of 11 to 13 weeks because our blood tests and our prediction models are based on a particular size of your baby. At this particular time, we're basically looking for something called the NT. NT is the nuchal translucency, that's the fold at the neck of the baby. That tells us if it is more than 3 millimeters or it is thick, then it tends to give us an idea that there may be some problem with the baby. This ultrasound, apart from helping us to detect what is the risk, it is also considered as a first anomaly scan. Because at present, with the good machines, we are able to detect several defects in the baby in this particular trimester itself. We no longer need to wait to go up to the 5th month to be able to detect the other defects. Many defects of the brain, many of the other defects which we refer to as of the neck can be seen at this particular ultrasound. We also look at the blood flows that are going into the baby. Are the blood flows restricted? Are the blood is going freely into the baby? This also helps us to predict what are the chances that your baby later on will be small in size as compared to normal babies. What are your chances of developing high blood pressure at a much later stage, that is the 7th or the 8th month or the 9th month? Thus, this particular ultrasound is a very, very essential ultrasound. It helps us to look for chromosomal defects. It helps us to look for any structural defects. It also helps us to predict what are your chances of developing complications later. At this ultrasound, we also recommend you to get a blood test, which is referred to as a dual marker. And we get a combined report of your ultrasound as well as these biochemical markers. And that risk tells you either as a low or a high risk to have any of the chromosomal defects that I've talked about. That's 21, 18, and 13. Since this is only a screening test, since it only tells us the risk, if the risk is low, we do nothing beyond that. But if the risk is high, then we move ahead and either ask you to get an NIPT done or we ask you to get an amniocentesis done, depending, I would say amniocentesis or a CVS done. That is we refer to as an invasive procedure, depending on the risks that have been found on this particular test or if there are any of the structural anomalies. Coming on to the next ultrasound that's done between 18 to 20 weeks of pregnancy. This is the anomaly scan, also called very simply as a level 2 scan. This is one ultrasound where every part of your baby is evaluated by the ultrasonologist, from the head to the toe. They tend to screen for any of the structural defects that can be detected. It may take sometimes 1 hour, it may take 1.5 hours, sometimes it takes even longer if the baby's position is not right and the ultrasonologist is not able to see the face of the baby. They also do a cardiac screening. They do a screening for the heart defects. But since the heart is not completely developed at this time, it is recommended that a fetal echo is done between 22 to 24 weeks to be able to evaluate the baby's heart in detail. So, the structural anomaly scan is the most essential scan of the pregnancy since it helps us to detect any of the anomalies that may be present or defects that may be present in the baby, which may not be compatible with the baby's life, or if there are certain defects which are compatible, which we can follow them up much later. Next ultrasound after this is done somewhere between 30 to 28 to 32 weeks of pregnancy. That is called the fetal growth scan or the fetal well-being scan. This is also another relook scan for looking for certain anomalies which may not appear between the 18 to 20 weeks and tend to appear much later during the pregnancy. This includes certain defects of the brain, which is hydrocephalus. It also refers to certain kidney defects, which are not seen at 18 to 20 weeks, but are picked up later between 28 to 32 weeks of pregnancy. Apart from being a relook scan, it is also a growth scan. That is where we see how the baby's weight is growing. We also look how the liquor or the fluid around the baby is. And it helps us to detect those babies who are at risk of having fetal growth restriction. That means who are at risk of being very small at the time of delivery. We have seen in our country that if we tend to miss out these babies who are going smaller for their gestation age, whose growth curve is much less, this contributes to significant amount of sudden deaths in the pregnancy, or will be referred to as IUDs in the technical terms. So this ultrasound is also essential ultrasound. Following this, then one ultrasound again is done between 35 to 37 weeks of pregnancy. And that again is a growth scan. It is again a relook for any anomalies that can be detected. And this ultrasound is the final ultrasound if everything is going fine as far as the pregnancy is concerned. In case in any of these ultrasounds we find that the growth is less, or if the mother is at high risk in the sense that she has got multiple pregnancies, she's got high blood pressure, she's found to be a diabetic lady, she's an elderly woman, then after 28 weeks, we recommend ultrasounds every 4 weeks to see how the fetal growth pattern is. And based on the growth pattern, based on the blood flows that are going into the baby, we may sometimes in the high risk pregnancy need to deliver the baby at a right time, where the baby would do better outside than the baby would do inside. So, for a normal low risk pregnancy, minimum ultrasounds that we do recommend is 5. In case patient is reluctant, or in conditions where money is an issue, then at least 4 ultrasounds are recommended. The last ultrasound we do somewhere about 32 to 34 weeks of pregnancy instead of 2 ultrasounds, that is at 28 and 37 weeks of pregnancy. I would also now say that ultrasound should preferably be done by an ultrasonologist who has a keen interest on fetal medicine, person who's experienced in the study of the baby or the fetus, who's good at detecting the anomalies, good at detecting any growth difficulties, at doing a Doppler, so that each ultrasound has a meaning. Each ultrasound comes out with a value which helps us to manage and monitor the pregnancy well and give the best outcome, which is a good baby and a healthy mother. The ultrasound that we do at 18 to 20 weeks, that is the third ultrasound. We also look at the cervical length. That is the length of the mouth of the uterus. This preferably should be done by an internal scan. because this helps us to predict what is the chance of your baby delivering in the seventh or the eighth month. At this time, if we get a cervical length that is more than 30 millimeters, then we are quite sure that the pregnancy is going to pull till term. But if the level comes less than 25 millimeter, we are cautious that the chances of delivering earlier are much more. Hence, an ultrasound is not just an ultrasound. It tends to give us a lot of information about the well being of the pregnancy, loads of information as to how to manage a particular pregnancy, and what steps we can take to prevent an early delivery, to prevent an unfortunate event like a fetal death, and to determine a time when we are able to give a healthy baby to a healthy mother. So, my main purpose of this talk was to first bust the myth that ultrasound is not good in pregnancy, it's not safe for the baby, and to give you an information as to the need and the purpose of each and every ultrasound that your obstetrician tends to write to you, so that you're well satisfied, so that you do not have questions and you do not doubt the reason for it being done, and you enjoy getting an ultrasound done. So, with that, I come to the end of my talk. And if there are any questions, I would like to take that.
Yes, ma'am. Thank you so much for a wonderful session. It was so simple and clear that I am sure not many would have many questions, but I have two here, which I got from the patient. So one was, how many USGs are important or mandatory in high risk pregnancy? So is there any number where which they have to undergo?
So, as I said, the difference in a low risk and a high risk pregnancy starts from 28 weeks, that's your seventh month of pregnancy. In a person who's low risk, we do just two ultrasounds, one at 28 to 30 and the other we do at 35 to 37. While a high risk pregnancy will require an ultrasound every 4 weeks starting from 28 weeks of pregnancy. So you're looking at 28, you're looking at 32, you're looking at 36, and if you're not delivered, then one just before your delivery. So number of ultrasounds have nearly doubled after 28 weeks.
Ma'am, there's one more wherein the patient is asking about what are the signs of bad ultrasound? How do you decide that the ultrasound done was not right?
Okay, so this is not for the patient to decide, first of all, right? So no patient is the one to tell, yes, this is a good or a bad ultrasound. The satisfaction is a different issue, which a patient will be able to say, I was not satisfied with the way it was done. But the quality of the ultrasound can be decided only by the obstetrician who tends to see the report. So when we are looking at the report, we are actually looking whether all the parameters have been well covered, which you see as a growth scan. That is all the growths of the various parameters, whether the lichen has been mentioned about it or not, the position of the placenta, the grading of the particular placenta is there, and ultimately they have been able to give us a conclusion at the end. Another thing we obstetricians always do is look at the images that have been provided to us. Those images are also very important because when we look at the images, we are able to identify the quality of the ultrasound, the machine, as well as the person. So many times I would say that sometimes the images may not be too good. So it is not just the machine, but even the person who's sitting behind the machine is also very important. So every obstetrician tends to maybe identify some of the ultrasonologists they are comfortable with, whose reports they would accept as to be all right, and whom they can communicate with them in case there's a problem. That's very important. That if I feel something is not okay or if I need to step, I should be able to ring back the ultrasonologist and ask them for a clarification. So it's a two-way process. So neither is obstetrician correct nor an ultrasonologist is correct. It's how we interpret the report considering your situation. That is the criteria for it.
Right. Thank you. Thank you so much, ma'am. No more questions, and it was really wonderful knowing about it. You have the myths have been cleared very nicely, and the simple way you have put it forward is amazing. Thank you so much, ma'am. Thank you so much for the
It's my
session.
pleasure. My pleasure.
I will
Thank you
end the
so much.
broadcast. Thank you.
Okay.
Thank you.
Bye-bye. Bye.
Bye.